All right. Hello and welcome. My name is Sarah, and I'm a volunteer for the MAVEN Project. Thank you all for joining us today and our friends at our Anchor Clinic, which is International Community Health Services, for hosting today's session. The session title today is Lower Extremity Wound Care in the Outpatient Setting, presented by Dr. Lisa Gould and Dr. Elizabeth White-Chu. Just some brief information about these two physicians. Dr. Elizabeth White-Chu is a geriatrician and wound healing physician. She is Associate Professor of Medicine at OHSU and the Medical Director of Wound Healing Program at the Portland, Oregon VA Healthcare System. And then just a little bit of information about Dr. Gould. Dr. Lisa Gould has been practicing plastic and reconstructive surgery with an emphasis on difficult wound problems since 1999. She is an affiliate professor in the Department of Molecular Pharmacology and Physiology at University of South Florida and clinical associate professor of medicine at Brown University. And with that, we'll go ahead and get started.
Great, thank you. I just want to emphasize that I will call her Foy because that's what I call her, and I'm Lisa. And
Change
you
it
can call us
on
by
my
our
thing.
first names.
Okay.
We both practice wound healing in an outpatient setting, but we have tried to gear this for the non-wound physicians because we know not everybody practices wounds as their profession. I do some consulting and those are listed, but that will not influence anything that we're going to talk about today. And as you know, you're going to get some CME credits for this. So today we're going to outline the common etiologies of lower extremity wounds in general, look at some diagnostic studies and determine if there's barriers to wound healing, identify health-related social issues that can prevent wound healing, and then help implement a wound healing plan. Oops. But first, we want to ask some questions so that Foy and I can understand our audience a little bit better. First one is, have you seen a lower extremity wound in the past?
No.
Sorry about that.
That's
Okay. Oh, so we can even answer the poll.
okay.
If you see the poll come up on your screen, you can just check the buttons boxes.
Sorry, Foy, it says host and panelists can't vote.
I know, I can't vote. Bummer.
I feel like we should have some do 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 do.
There you go, you can do it.
Do.
All right, I think we'll give it about 10 more seconds. I can still see. Oh, people are.
The answers coming in.
Oh yeah, high percentage too. This is great.
Nice, it's good.
Hi.
Okay.
All
So it
right.
looks like we're seeing that you are seeing wounds. Even 14% have seen them in the last day.
Yeah, that's great.
Quite a bit of confidence.
Good.
And then it's hard to answer. Let's see, if you were not confident, do you wish you knew more? I don't see the whole thing there.
I think we scrolled down.
Oh, there we go. Scroll down. Okay.
Treatment.
How do you treat it? Okay. All right. Well, so we're going to talk about different kinds of wounds, but one of the points of this presentation is that when you hear hoofbeats, think of horses, not of zebras. And the most common lower extremity ulcer in the outpatient setting is a venous ulcer and caused by venous hypertension. And so you'll see on the right, two different pictures. One is of a very, very typical venous ulcer. And then further to the right is what I would term phlebolymphodema. And that's when someone has venous hypertension, but then they get a secondary lymphedema because the amount of fluid has just overwhelmed the venous system. Then the lymph system is supposed to pick it up, but that's overwhelmed as well. So they have a combination of venous insufficiency, which you can tell by that dark stained skin, and then the edema that now affects the foot as well, and it's woody and it's thick and hard to manage. And that's as opposed to just straight up lymphedema that often occurs in people that have had radiation, or even in obese people. We're seeing lymphedema of both extremities because it occludes those very, very delicate lymphatic vessels, sometimes also related to trauma or from cancers, having had surgery on the lymph nodes, that sort of thing. Most of us know to be aware of peripheral arterial disease and the ulcers that can be caused by that. But we often overlook that neuropathic foot ulcers can be from things other than diabetes. It can be from HIV, vitamin B12 deficiency, alcohol use, even spinal stenosis, and sometimes it's just idiopathic. We can't figure out why they can't feel their foot, and then they get a wound from repetitive trauma because the patient's not able to feel their foot. And we'll talk a lot about, or a bit about, skin cancers that can present as an ulcer and are often misdiagnosed because we try to heal them and they don't heal, and we wonder why.
Great. And so when we think about some of the risks for leg ulcers, I'm sure you know many of these, but I always like to review them and get back to basics. So when we're talking about on that upper left, screening for smoking, and every time asking people whether they might be ready to quit or at least cut back. Quitting is better. Really, when we're looking at this is a Charcot foot, so looking at on the next one over, looking at if there's a rocker bottom deformity and whether they might need some prescriptive footwear for prevention. Um, Hyperlipidemia, that's the nice cholesterol rising to the top there. And older age. As we get older, our skin changes, the balance between our oil glands and our sweat glands. We might be on multiple medication. I say we because it's going to happen to the best of us. That we might be on different medications that could thin our skin or make it more prone to injury, and having multiple comorbidities that can impact our skin. Lower left is that diabetes management. So screening for diabetes and having a low threshold to check, even if you think that they're fine. Um, and then any kind of leg surgeries. So anytime you've had any kind of disruption, whether it's a big ankle surgery, knee surgery, hip surgery, that's going to disrupt the lymphatics and potentially the venous system as well, putting them at risk for leg ulcers down the road. And then finally, blood pressure, high blood pressure. So all of these are risk factors for leg ulcers of various causes. Next slide.
When you first see a patient, the thing that we have to think about are what are the red flags? Oops, it keeps advancing too many times. What is going to send a patient to the emergency room? So a spreading infection, hot swollen leg, limb-threatening ischemia where it's cadaveric and they need to see a vascular surgeon right away, swelling with pain in the calf that could be a DVT, or even a suspected skin cancer. That doesn't have to go to the emergency room. But if they have a lot of edema, think of heart failure. Also, sometimes end of life can be one of those problems. If they're not a red flag, it has to be taken care of right away. Just start considering other causes and getting other specialists involved. We can't all handle all of the problems ourselves, so we have to think about other things, and we'll go more in depth as to what some of those other things could be. But once you kind of sort through that, within 24 hours of seeing that patient, start doing some wound and skin cleansing, a simple low adherence dressing, so something that doesn't stick to the wound but still can absorb the fluid, and then light compression. So we don't, until you start getting some studies, if you don't have time in the clinic but you want to just get patient history and get the patient started, you can do some very light compression, less than 20 millimeters of mercury, to try to get the swelling out. And then when you see them back within the next 14 days, do the complete assessment, the whole past medical history, really going over that leg with the ulcer history, a wound assessment, and then the vascular assessment. So we talk about the ABPI or ABI, which is the ankle brachial pressure index. If it's less than 0.5, that warrants an urgent referral to the vascular center, especially if they have an open wound, and stop compression because you can make it worse. If it's in between 0.5 to 0.8, again, it's reasonable to get the patient into a vascular surgeon. They have some mixed disease, probably venous insufficiency and arterial, but they can still tolerate light compression. And then if it's normal, they probably have venous insufficiency, and you can carry on that way. If it's real high, and Foy will talk about this more, consider that they have calcifications that are keeping you from being able to compress those vessels.
Great. So here we have a diagram of how you would do an ABI. And the way to be done correctly, you do have some time, or you need to mark off time to do it, and you can, there are competencies available to teach nurses how to do this as well. So you want to make sure that when you're doing it, that you take the higher of the two brachial pressures for both the right and left legs. And so that you're taking your highest brachial pressure, sorry, for your right arm, and then comparing it to both the right and then the left. And the arm pressure is that surrogate for that systemic blood pressure. If you have a really big difference of blood pressure between the two arms, then there might be some narrowing or blockage in that arm artery causing it to be lower. So that's why you want to make sure you take the higher of the two arms. And then as she mentioned before, where if the highest risk or risk factors for having non-compressible or that medial arterial calcinosis and stiffening of those arteries is primarily diabetes and age, which I don't know about you, but those are all of my patients. So I will have people who have non-compressible arteries, and we'll still try and do maybe just some low compression, assuming they're not showing other evidence of ischemic disease, and then probably doing a referral to a vascular center unless if there's not any wound healing and the wound is stalled.
And I'll add that we've taught our nurses all do competencies on doing ABIs, and I had my doubts about several of them. And then when we had formal studies done in the vascular lab, they were spot on. So it definitely can be done in the clinic. I did ask Foy, what do you do when a patient has a wound that's too painful and it's on the leg and you want to do an ABI? In my clinic, the nurses defer to me, and I may defer the ABI and just continue light compression until we can get some more formal studies.
And here's an example of a more formal study. So this will be done at a vascular imaging center, depending on how your local area that you would order, maybe segmental pressures or PPG. But what you want to see, especially you'll notice, so what they're doing is they're doing those arm pressures.
It keeps advancing.
Okay, that's okay. And so you have your arm pressures, just like they're taking a regular blood pressure. And then they are also checking it at the ankle, the transmetatarsals, and the toe pressures, assuming everybody has their great toes intact. And they want to see that nice, you'll see that along the top of especially these posterior tibials, either a biphasic or even a triphasic, which is a robust waveform. And as it descends, what you don't want to see, which is unfortunate in this patient, especially on the left toe, is it effectively to flat line. So they don't have any blood going to that left toe. And if they have a wound on that left foot, then they don't have adequate blood flow to close the wound. You want the toe pressure to be greater than 30 to feel confident that you'll have adequate blood pressure. But I will say that if you're fostering the healing and it's still not doing well, and they're kind of in that borderline where 48 is kind of approaching borderline, I would then refer them to a vascular interventionalist to see if there's something more to improve that blood flow.
So this illustrates what the normal venous system is like. And in most of us, when we're supine, the pressure at our ankle is 6, but then when we're standing, the pressure at the ankle is 90. So you can see why we might get venous insufficiency, and those delicate valves that are in the veins get destroyed if we're on our feet forever, or we get in an accident and you get a DVT that disrupts that venous system. The more pressure you have in the ankle, then it just builds up. On the right is the normal venous system. It's a deep system and a superficial system that's then connected with perforating vessels. And there should be one-way flow from the toes back up to the heart. And not only do the valves promote that, but the calf muscle pump promotes that as well. So when we walk heel, toe, that helps push the blood back up to the heart through the deep system. And that's when the valves close normally, that's what happens. So when you order an ultrasound looking for venous insufficiency, you want to make sure that you specify it correctly. If you just order a venous ultrasound, what will probably happen is that they look for a DVT or thrombus, as is shown on the left. You have to specify that you're looking for valvular incompetence. And on the right, it shows a normal valve on the top where there's a crisp cutoff and then nothing, so you're not getting any backflow. And what the ultrasonographer does is they put the cuffs on and then they squeeze the leg to try to push it back, push that flow back up through the valves to see if they're competent. So down below, you see that it tries to close, but then there's this kind of swirling and whoosh where it's really, you're getting a lot of backflow. And they'll measure the number of seconds that goes on, and that tells you the degree of venous insufficiency and valvular incompetence. And that can be really helpful. So just remember, specify. If you're looking for valvular incompetence and you specify that, it's a totally different test than a DVT study.
Right. And so here we look even further, a little bit more closely, is like, well, what is venous hypertension? And it's high blood pressure in the veins. But what's really interesting that we have found, they've done some studies looking at these healthy subjects. Well, first, let me draw it to your left, excuse me. So this is a good diagram here that shows an ulcer on the left side of the leg here, and looking at this superficial system and what they even call fibrin cuffing. And that's where you'll have these pericapillaries with their fibrin will start to cuff. And that's the theory about how the wound might occur in this setting of where you're having high blood pressure in the veins, decreasing the microcirculation and potentially causing a local ischemia and wound ulceration. Especially if you have a dysfunctional perforator vein, those communicating veins, then you can't release that venous pressure very well. Now, if you look on the right side where we have this diagram of a standing person, what they've looked in healthy subjects when we walk, and we're doing, again, that heel toe, which factors into our counseling and education for patients, our pressures in our legs and our veins will drop precipitously. But if we have any superficial perforator or even deep venous dysfunction, it won't drop nearly as much. That doesn't mean we don't counsel people to walk. We still do, but it does mean that we have to do other interventions to really improve the venous pressures. And then the thing to really take into account is if there's any deep venous outflow obstruction. So there are people who, with obesity, may have that really large pannus, or people in really bad heart failure, kidney failure, liver failure, where again, they're having that outflow obstruction, or a DVT that's at the level of the groin. These are all things where actually the pressure will increase. So that's good to keep in mind in terms of setting realistic expectations for healing and intervention and how we help these patients. So going from left to right here, you'll see that these are some of the things, as I mentioned, the venous hypertension leading to the venous insufficiency. So looking at, you'll see this hyperpigmentation, and that will never completely go away. People will ask about that. Lipodermatosclerosis, I love that word. I just break it down. So lipo is like the fatty tissue, derma underneath the skin, and it's sclerotic, it's scarred down. By its nature, it's hypovascular and can be really hard to heal in that area. And atrophy blanche, which you can see in this person with darker skin and also with lighter skin in the middle photo here. This is a non-specific finding in the case of venous insufficiency, but can be extremely painful. So it's usually a white skin with these pink dots in there. And again, just keeping in mind that when the patient says it hurts, it's definitely very painful. And then lastly, you'll have this non-healing wound with the phlebolymphedema, which is what we want to try and prevent or at least rapidly close. So going on to how does this all pull together? I think if I want my one takeaway, Dr. Gould might have a different one. My one takeaway that I want you to remember is that all edema is lymphedema. Okay. So on the left here, we'll see that there's this, it's a glycocalyx theory, where you have all this perfect storm of ischemia, where you have direct damage to the glycocalyx, this microvascular dysfunction that causes an increased adhesion of white blood cells, inflammation and trauma, especially in patients with sepsis, have these increased inflammatory mediators, and then they get all that capillary leak. If they have any underlying atherosclerosis, they'll get deposits with inflammation and plaque formation, and that makes your platelets really sticky. And then diabetes increases your vascular permeability, also a microvascular capillary leak. So when that happens, you're getting all that edema, and it's lymphedema because it's all getting into the lymphatic or into your extracellular matrix, and your lymphatics cannot keep up with that. So on the right, when people have diabetes, they get it hit twice. Not only do they have the capillary leak from the elevated glucoses, but they also have their lymphangians, which are lined with smooth muscle. And if they have any neuropathy, that is not being innervated and not working appropriately. We know that patients with foot ulcers and edema have a much higher amputation rate. So really keeping in mind, knowing, again, when you're thinking about that triage and severity and thinking about that. So Dr. Gould touched on this briefly about compression. So, okay, well, what do? I want to do some light compression. This one across the top, there's a trade name for it. And I'm just going to go ahead and, because I don't know of any substitutes. It's called Tubi Grip, but it comes in a box, and it's a really very light elastic stocking that if you can find a resource in your clinic to have it stocked would be great. Essentially, it applies maybe just 5 to 8 millimeters of mercury of compression, where you can put that. It's great to secure a dressing as well, and it can help just a little bit of that swelling get out while you're still contemplating whether they can tolerate higher compression. There are also, depending on your resource environment, if you know physical therapists, occupational therapists, or nurses who have been lymphedema certified, that they can do custom compression wrapping for your patients and lymphatic massage and teach your patients how to do their own lymphatic massage. And then lastly, there's prepackaged wraps or garments in both 2-layer and 4-layer that you can use for your patients in your clinic. So thinking about this compression information, if you look, in wound healing, we have actually quite a few things that have some robust randomized data, and this is definitely one of them, where the take-home message is some compression is better than none. So this is Cochrane level data, multiple studies, been repeated multiple times. Some people on this call might be most familiar with the Una boot. That's the zinc impregnated gauze. And then if it's a Duke boot, it's followed with the self-cohesive bandage. That's the most common way it's done. That is an inelastic compression. And then if we look at more the multi-layer or multi-component compression, where there's some really long stretch or short stretch, and that literally means what I just say. You pick up the bandage, how far can you stretch it? That when we look at the multi-component compression versus a completely inelastic system, the multi-component is more effective. That doesn't mean the inelastic doesn't work. If that's what your system can afford and can do, that's great, because some is better than none. But the multi-component is more effective, and the 2-layer and the 4-layer are equal. One is not inferior to the other. So why do we care whether it's elastic, inelastic, multi-component? So with the Una boot or the Duke boot being an inelastic system, when the patient's just sitting there not doing anything, it has a low resting pressure. But as soon as they start walking, it's because it's a stiff system, very high working pressure. While a multi-component or both elastic and inelastic does a more even pressure throughout, both with resting and working pressures. I do like to reserve my Una boots for some patients where if I know that they have adequate arterial supply, but it's still kind of borderline and they don't walk. So I'm thinking more about my frail older adults in nursing homes who are wheelchair users. An Una boot might be a great way to start, and it's also an easy modality to teach, to the nurses. So there's physics behind all of this. This is Laplace's law, sort of. It's been a little bit modified. But what I'd like you to think about is that sub-bandage pressure, which equals the bandage tension times the number of layers times a constant, over the diameter of the leg times the width of the bandage. So bandage tension can be a little subjective, but there are products out there that have wonderful markers. Maybe it starts as an oval, and when they stretch it, it becomes a circle, or vice versa. Ways to cue the nurse so that in terms of doing adequate compression. And the number of layers. So if you increase the number of layers, you're going to increase that subbandage pressure. The diameter of the leg is important. If you have a really large person, you're going to have less subbandage pressure, and so you might have to kick up the number of layers or the tension. And then the width of it bandage is extremely important. I always like to share the anecdote of a patient who had gone to the emergency room with a leg wound. The emergency room provider has prescribed the right compression. The pharmacy made an error in the dispensing, and they dispensed, instead of a 4-inch width bandage, they dispensed a 2-inch width. And then the person returned back to the emergency room in several days with wounds all up and down their leg because the subbandage pressure was too tight. So the take home is, these are the medications. It's not a pill that we use to treat this phenomenon. This is the medication we use to treat, and there are consequences if it's applied wrong or prescribed incorrectly. Often you'll have patients complain of how to keep the layers up. There's a lot of tricks out there. There's some kits that have cotton batting as the first layer. So some people find rolled gauze works better. Using a ton of Vaseline, some kind of skin emollient at the top to really keep those layers on. There's the spray bandage. I get a little nervous of taping the bandages directly to the skin. Probably that's because I'm a geriatrician. I have people with very thin skin. On the right here, we do not use ACE wraps in this compression. The problem is they're great at reducing edema, but the very next day, it's reduced the edema so much that it tourniquets and causes all this problems up and down the leg. So it's not a great way to provide compression.
Yeah, they're long stretch, so it's hard to control how much tension someone
Very
puts
good
on it.
point.
They can wrap them really tight
Yeah.
and over tighten it. So that's why we
Absolutely.
talk about the short stretch versus the long stretch.
Yeah, really good point. And then here is where you can get pressure ulcers, pressure injuries, if a compression wrapping is done wrong. In the upper left-hand corner, those malleoli will need to be protected. Sometimes what I'll do is again, thinking of Laplace's law, I will increase the diameter by padding it up with ABD pads. And so you're reducing that pressure that's going to be directly on that area, and try to redistribute it a little bit better. The bottom one here this is a little bit of a wonky photo, but this is a foot, and then that's the anterior tendon that you see between the leg going up and to the right there, where it had been tied way too tight right across the top of the ankle and caused a nasty pressure injury to where the tendon was even exposed.
So I think you're probably gathering that it's not just one treatment that works. So it's a multimodal treatment in order to help almost all leg wounds. Most people have some underlying venous insufficiency by the time they get to a ripe old age of 40 or 50. So exercise, making that calf muscle pump work you can just do toe raises at home. Walking is really great if they can walk, and especially emphasizing heel toe. Walking with a walker is still walking, and it's better than not walking. Using the compression wraps, there's a wide variety of stockings that people can get online now. They're colorful, they're fun, they're pretty much easier to put on than some of the others. I get mine from even just from a sporting goods store. You can get even up to 30 to 40 millimeters of mercury if you want to go that high. And then over in the right lower, that shows somebody getting a venous ablation. So the vascular surgeon is looking for that perforator or the superficial venous system, and they're going to ablate that, the feeder vessel that goes to the wound. And then more veins will grow, and they're not going to be short on veins, but that can help the wound heal. And it's been shown now that early venous ablation actually helps heal wounds and keep them away. So it used to be that we thought it just prevented recurrence, but now we know that early ablation helps heal wounds.
So this is a funky little graph that I use for patient education, where I explain it to the patients, where They did a meta-analysis and systematic review. It was about 6 studies, all randomized control trials. And you'll notice, so at the top, you have your progressive resistant exercise. And I even did a deep dive and went, well, what would that look like? So that's calf raises. And it's starting from doing calf raises while you're sitting and a certain number of reps that you increase each week. And then you're standing and doing it on both feet. And then if the patient has decent balance, going from one leg to the other. So that's your progressive resistant exercise. And then they also had walking 10,000 steps and other studies. But what really moved the needle is if they did both. So I'm constantly, every time I'm seeing the patients, I talk about my homework, which is, figuring out other underlying issues and the right compression and, making whatever wound product that I choose to do in the debridement. But their homework is figuring out exercise, walking, and the progressive resistance. I'm constantly asking about how they're doing on that. If there are issues with back, hip, knee, ankle pain, any of that, I'm working with their primary care doctor or even a physical therapist to increase their mobility. And I so stress that yes, walking with a cane or walker is walking. People think it's not, it is. And even with people with heart failure, there is, maybe cardiac rehab. So all these types of things that we can help our patients with.
Yeah, there's a study in Sweden that's ongoing, and they have a lot of resources to be able to go into the home. But one of the things that was emphasized is meeting the patient where they're at. So they may not feel comfortable, walking down a whole street, but they may like to walk to the mailbox with their granddaughter. And so we talk about, start with that, and then they can build from there. They might even want to check the mailbox a couple times a day. And that gets them going, and then they start to feel more comfortable with it. It's kind of the same thing with the compression. They're not comfortable with the compression at first. They start with light compression, and then they realize that they actually feel better. Their legs feel lighter. They can walk easier. Their ankle doesn't hurt so much because that compression. And then you can start to go up on the compression, because a lot of our patients will say, no, this is too tight. Take it off, take it off.
Yeah.
So we like to start low and build up. But what about infection? So, we see a lot of people getting admitted to the hospital with infection. I don't know where about you, but our hospital is overburdened. We have 540 patients in a 375 bed hospital, and they're getting antibiotics that they may or may not need. So what we want to emphasize in wounds is that all wounds have some bacteria in them, but it's our job to figure out, is it an infection that needs systemic antibiotics, or can we treat it locally? And this nice gradient that was put out by the International Wound Infection Institute talks about that, where it's contamination to start with, it can build up to colonization, local wound infection, which may be covert or overt. Overt, there's purulent discharge and the wound starts to break down. They have increasing pain, malodor, and some erythema. And then a deep dive into that article pretty much says that as you start to get more erythema, if it's 2 centimeters or greater from the edge of the wound, that's an overt or a spreading infection that warrants systemic antibiotics. That's really a cellulitis around the wound itself. Otherwise, it's just the wound and the inflammation related to the wound. Obviously, if there's lymphangitis, or the patient has systemic signs and symptoms, they warrant systemic antibiotics. But we often see erythema, necrotic tissue, but then as you start to get increased drainage, increased pain and malodor, that's a wound infection. So again, all wounds are colonized, not all wounds are infected, and somehow we have to decide whether they need topical or systemic therapy. If they're getting systemic therapy and you don't have a wound culture, say it's just cellulitis and not an open wound, you have to figure out an empiric therapy, or you're waiting for your cultures, you would treat the usual suspects, Staph aureus, strep pyogenes, and Pseudomonas. And then in the meantime, ideally, we have culture-guided therapy. So a swab or a biopsy, very few people are able to do biopsies because you're creating a wound. So you're going to swab. But there's no benefit to culturing at just necrotic tissue. That's going to have multiple organisms in it, and then you are stuck with trying to figure out what to treat. What you want to do is clean up the wound first and then get the culture. The Levine swab technique is tried and true. I mean, the date on this publication, 1976, right? It's old, but then it's been compared to biopsies of the tissue, and it correlates pretty well. So the idea is you clean the wound with sterile saline, but not with an antibacterial. You know, some saline has antibacterial elements in it, or you might clean with an antiseptic. You don't want to do that. Just clean with sterile saline, and then sample a square centimeter area with enough tissue that allows the fluid to get up into that swab. Now, our swabs are pretty bendy, and you have to push, and you kind of press and roll and press and roll and press and roll in a square centimeter area. And that brings the fluid from the deep tissue up into that swab, and that gives you the most accurate result. And it doesn't really hurt. It's gentle. It's a lot less painful than doing a biopsy. All right.
So here, here we have a quiz, if I remember correctly. So not all red legs are due to cellulitis. So A, B, C, or D. Which one do you think is cellulitis?
Sarah, do we have a poll on this one?
We do.
Okay. And as you're looking at it, you'll notice that the date on this publication is old, I think it's 2011, from a dermatology literature.
And can anyone see the poll?
Not right now.
Not
I couldn't, but I saw it for a flash for a second.
I saw. Okay, let me relaunch it real quick. Let's see
Okay.
here.
There, now
I see it now.
Okay, beautiful. All right, we'll just wait a few more seconds. It looks like we've got 60% answered here.
Okay.
All right.
Oh, you guys are great.
Awesome. So funny enough, in the actual study, none of them were cellulitis. Although I agree with you that A is definitely the most concerning. And I think they were all determined to be stasis dermatitis by a specialist in the study. I'm curious, this is where a picture only goes so far. So I'm wondering about on A, the top left, that it might have been if there was more of a history of itching, and maybe that if they took the sock off, there was no, the foot was spared, and it wasn't looking necessarily like an obvious cellulitis. Okay, next.
Oops, I got to click on a slide. There we go.
Okay. So this is one of my favorite studies. What I loved was the infectious disease doctor brought it to my attention when said, "Foy, we were right all along." So this was back in 2020, where they did a hospital study. They randomized people. So people who came in with cellulitis of the leg, they had criteria in determining whether it was cellulitis, and it was an infectious disease was involved. And then they were randomized. Everybody got hygiene and education regarding hygiene, and then they were randomized to either compression garments or not. It was a randomized control trial study, so high level study where they really made sure compliance with the garments. But they actually had to stop the study early because it was such a significant difference in preventing recurrence of cellulitis. So those people who were wearing the garments and had had the education on the hygiene were less likely to come back with another hospitalization. So the take-home message of this is that swelling is a pro-inflammatory process, puts you at risk for that infection. Controlling that swelling with a medication being the garment, greatly reduce bad outcomes. Okay, so now we're going to have a few I think 3 slides altogether where it's dermatitis, cellulitis, or other. So Kristen and Sarah, if you can launch that for this slide.
Right.
Sorry, you want to hit the back button at the top?
Okay.
Hold 3. There you go. Perfect.
Awesome. Thanks for your patience.
So while you're doing this, I'll comment that they one study that looked at this, that as many as 28% of 145 subjects were misdiagnosed with cellulitis. Almost 40% actually had stasis dermatitis. That was that 2011 study. And we talk about this as bilateral lower extremity erythema and edema, often seen in venous hypertension.
And commonly known as BLE.
BLE, that's right.
It's not so
That does
bleep.
not cause glee.
Right.
Okay.
How are they doing, Sarah?
Alrighty, we are at 57%. Let's give it a few more seconds here. Okay.
Okay. So image A being dermatitis, I would agree with that. Image B, some people say dermatitis, some cellulitis. This is actually a great photo of lipodermatosclerosis, which you can have acute lipodermatosclerosis that can look like cellulitis. And then the last one looking dermatitis or other, that's a great photo of atrophy blanche. Great. Okay.
Yeah, I will say the problem with when we did the study with BLE at our local hospital, we actually looked at the number of patients that got admitted and how many times they got antibiotics. And then so I lost my train of thought. But it was a recurrent thing. So what happens is patients get put into the hospital, their legs are up, their edema goes
there you go.
down, and the redness goes away. But of course, the patient and the treating physician says it's because of the antibiotics. And so that cycle, it's like a rinse and repeat. It just keeps going on and on. And so we all think that it's the antibiotics when it's not necessarily. Here's another fun quiz.
Yeah.
This is
So
your last quiz.
No, I think there's one more after this.
Oh, okay.
And I'm seeing the questions in the chat. We'll definitely address them at the end. Thank you.
Okay, I tried to pull them up. I couldn't. Is this the right? Yeah.
Okay, how are we doing?
We've got about 50% or so answered, and we'll keep it open for a few more seconds here.
Okay.
All right, great.
Okay. So on A, dermatitis, definitely dermatitis and phlebolymphedema. So whoever said other, if that's what you were thinking, that's definitely the case. Image B, other. So this is a great picture of what we call of tinea pedis, where it has that moccasin type rash. So that's where I'm worried about more of a tinea pedis cause. And then C is a cellulitis. That was a patient of mine that had pretty significant heart failure and had increasing pain, redness. I think even had some fevers where we treated it with antibiotics, but also did the leg elevation and compression. Okay.
Yeah, I think that's a good illustration of the blisters that can come from just leg edema
Yep.
with heart failure. And they can turn into bad wounds that don't heal well.
Exactly. And then the last quiz, promise the last
Oh,
one.
yeah, you're right. It is the last one.
All right, we've got 57% answered. We'll give it a
Yeah.
few more seconds here.
Okay, great. So A, yes, for those who answered dermatitis, again, it's that bilateral, that's a classic BLE picture, bilateral lower extremity erythema and edema. And yes, B is it. That is cellulitis, my friends. So that's me standing in the background where I was rounding on the patient in the nursing home, looking at his legs every week. And you can kind of see on the top of his shin there, that was the wound I was treating. And it was total coincidence because I only go there once a week. I walked in and he's like, "My leg really hurts." And I pulled up his pants to see the redness streaking up the thigh. And we caught it so quick, and we were able to arrange IV antibiotics in the nursing home and such. So that was really just fortunate. But that's a very classic cellulitis.
Very good. So, we said that original article in 2011, that's old, right? But we're still having this problem. This was another article from Journal of Hospital Medicine, but it was from the dermatologist saying that they're having trouble. They have a hard time diagnosing cellulitis, and a lot of patients are being admitted to the hospital when they really don't have a cellulitis. So it's one of these things just to keep you thinking about it. Is it really, really cellulitis? Is it stasis dermatitis? Is it something else? And keep that in mind. Their dermatologists are trying to come up with diagnostics, but I just read a recent article and I wasn't convinced that they truly had a good diagnostic for that red leg syndrome. Our patients have a lot of barriers to treatment, right? So we start compression and they say, no, I have pain, or some of our patients, especially those with some cognitive impairment or underlying anxiety, they rip off their compression in the middle of the night. And this happens to young people and old people. The cost is a factor. The compression stockings themselves sometimes aren't covered by insurance. Have to have a wound in order for them to be covered. So you order them while they have a wound. Some insurances don't cover them. They don't cover a pair. They only cover the one where the wound is. And they're about $60 to $90. Patients can't get them on and off. They have fragile skin that's going to tear when they're trying to put them on. They don't have any home services. And they complain that they can't take showers while they have that ugly wrap on. All those things can keep us from doing the right thing. And it's tough, right? So we have to coax them and talk to them. They can get cast covers for showers or bathe around it, but it's a tough thing. And then there's clinician factors. Foy and I both know that wounds care is not taught in medical school. It's not taught in nursing school. It's not taught in PA school. So it's nobody's
Not
fault.
taught.
They don't have it. And what?
It's not taught.
It's just not taught. Getting access to the supplies, you're in an outpatient clinic, you have limited supplies and it's hard to get what you need. You may not have the technical skills or nurses that have the technical skills to do the wraps. Immediate access to specialists. Not everybody has a vascular surgeon in their back pocket. And the time that it takes to do all of this wound care. We know that those are barriers. The graph down on the bottom, however, shows where patients go for their wound care and who provides the access. And it's really the primary care doctors and the community nurses that are the front line. It's not people like Foy and I that are in a wound center. So if the front line makes the diagnosis, at least we can get the patients into a specialty clinic in some cases. In most cases, we hope. Finding your local wound center, finding a vascular surgeon, even dermatologists treat a lot of wounds and have some pretty good skills with that. So I think, we don't blame anybody for not knowing how to take care of it, but we want to spread the word on how to take care of these problems. A while ago, 2016, I helped publish this article about a comprehensive algorithm for venous insufficiency. And the point is, you can work your way through, especially assessing for arterial disease and using the multi-layer compression. If the ulcer is healing greater than 40% in 4 weeks, you're on the right track and you just continue what you're doing. Modify the dressings as the drainage goes down and you get the wound healed, you're a hero. And then they go into compression stockings, and that is for their life. Those valves do not go back to normal. That is the treatment right now for venous insufficiency. And we've tried vein or valve replacements and they don't work. If the ulcer isn't healing, you have to start to think about going somewhere else. Does it look odd? Does it need a biopsy? Is it recurrent? Is it so difficult because it was been there forever? Get them into a specialist who can start looking at some of the skin substitutes, skin grafts. And now, this was in 2016. Now we know that they should be referred for venous duplex early, up where we first started thinking about multi-layer compression, because that can help the wounds heal in addition to preventing recurrence. There's a simple mnemonic. And so when a patient first presents, think of the 3 I's: infection, ischemia, and insulin/diabetes. Once you sort through that, then ADP, do they have atypical signs? Do they have distension and edema, which can be either venous insufficiency or some other source of leg edema, like congestive heart failure? Or is it a pressure injury, which it can be, and you have to be a bit of a sleuth and talk to the patient about where they might be getting pressure from. And so those are the kind of the way to remember what the wounds are and how to get a diagnosis.
Right. And I want to be mindful of our time. So although these are some important points, but I want to make sure we get to your questions. So really, what do you need in your clinic? We talked about having the ability to do an ankle brachial index, so having a Doppler machine and your blood pressure cuffs, having a way to assess the wound with a ruler. So you can get paper rulers, having a competency amongst your team members to make sure that everyone's measuring the same way, whether it's longest length by widest width or head to toe, et cetera. Talking about phone, or sorry, not phone, excuse me. That's how most photos are taken nowadays. I think that's why I said it. Camera, some way to take a photo, and making sure a ruler is in the photo. There is literature out there on how to do it properly when it comes to wound healing. You don't want to have your photo thrown up in a law, in a legal situation where there's not a ruler giving some perspective, because there are liability concerns with wounds, as with other medical issues. Cleansing. So there's some really easy ones, having normal saline, sterile water, but also Dakins, a 0.125%, or even acetic acid, 1%. And there's some easy ways to make that up in your clinic. And we can even send that out to the people on the call today on how to whip that up. Dakins is great for wounds where people are coming in where you're worried about their having a major infection. Acetic acid is really great for that heavy green drainage where you're worried about Pseudomonas. And then thinking about your primary